Well, good morning. I'm Todd Sears, and I'm the founder and CEO of Out Leadership. And I want to welcome you to the first of our This Week in Leadership video webcasts. I want to apologize for the slight delay. As you may imagine with technology, despite multiple rehearsals and trial runs, we always have some sort of an issue. But we're getting started anyway. One of our guests is on, and I'm hoping that our second guest will be able to join us, but we want to go ahead and get started. Just to give you a little bit of context, in the last 2 weeks, Out Leadership has tried our best to pivot our resources to make sure that we're delivering not just the content and leadership lessons that we do through our summits and our seminars and our salons, but also through virtual channels that we've been building and now obviously using in this time of the coronavirus. We've been able to pivot an amazing number of of our resources. Oh, great, Dave is on. And
good morning.
Good morning, David. Just giving a little introduction here. And one of the things that we've been trying to do is to build new and different resources to make sure that our member firms and our leaders in the community have access to information, as well as connections to the Out Leadership Global Network. So I want to start by actually thanking all 80 of our member firms of Out Leadership who have been so supportive of our work. And I also want to really thank our global sponsors, HSBC, Ropes and Gray, RBC Capital Markets, EY, and KPMG, because without all of the support of these organizations, we would not be able to do the work that we do. I also want to thank all the first responders, all those in the medical profession, two of which we have here with us today, who are working tirelessly and putting their own lives in jeopardy to help all of the country and around the world, those who are sick with this virus and with everything else that people would ordinarily get sick with. And a final thanks to my amazing team who have been working tirelessly remotely, as all of us have for the last couple of weeks, to make sure that we're still delivering what we need to deliver to advocate for equality around the world and to develop LGBT talent. So before we start the webinar, I wanted to read a quote that was shared with me by a mentor of mine, Suba Berry, who leads Working Mother Media. And it was a quote from Margaret Mead, who you may have seen the quote circulating, but I thought it was actually a great spot to start today's conversation. So I'll just dive in. Years ago, anthropologist Margaret Mead was asked by a student what she considered to be the first sign of civilization in a culture. The student expected Mead to talk about a fish hook or clay pots or grinding stones, but no, Mead said that the first sign of civilization in an ancient culture was a femur or thigh bone that had been broken and then healed. Mead explained that in the animal kingdom, if you break your leg, you die. You cannot run from danger, get to a river for drink, or hunt for food. You're meat for prowling beasts. No animal survives a broken leg long enough in the wild for the bone to heal. A broken femur that is healed is evidence that someone has taken time to stay with the one who fell, has bound up the wound, and has carried the person to safety and has tended the person through recovery. Helping someone else through difficulty is where civilization starts, Mead said. We are at our best when we serve others. Be civilized, be safe, be cautious, be caring. And I think that's a great spot for us to start today's conversation with Doug and David, and I'll introduce them in a second. I wanted to do this first webcast around HIV, AIDS, COVID, and the LGBT community because I found a frustrating lack of information. I found that our community was not being discussed. I saw maybe one or two articles about the potential impact of COVID on the LGBT community and those living with HIV and AIDS. And so we wanted to bring this webcast as the first of our weekly webcasts to ideally bring information to our community, to our leaders, to our companies, and to the broader community so that we are not only informed, but we have resources for action. So in that vein, Out Leadership has created a daily COVID briefing that my colleague Fabrice Hudar has been publishing, as well as this webcast, and we will continue to follow up with both of these leaders, ideally on a weekly basis, so that we can share whatever learnings they have for us that we need to know as a community. So to that end, I do want to thank a few other folks who helped make today possible by connecting us to these two fine gentlemen. The team at BIO, which is the industry organization for the biotech industry, and Dr. Martin Babler at Principal Health introduced us to Doug Nixon, and Douglas Brooks at Gilead, who was actually Obama's quote-unquote AIDS czar, was kind enough to introduce us to David Piontkowsky. So I'll just start with David. David is Vice President of Global Health for HIV Affairs at Gilead. And I'll just read you a quick quote that Doug Brooks, who introduced us to David, shared about him. He said, "In addition to being an amazing human being who, after representing the legal needs of people living with HIV and AIDS, went to medical school to then take care of us again as patients, which I think speaks incredibly highly of David and his work, and I want to thank him for joining us. And we're also joined, thank you for being here. And we're also joined by Dr. Douglas Nixon, who, in addition to being one of the leaders at viral immunology at Weill Cornell Medical, shared with me a couple of fun facts, including the fact that he has been kidnapped 3 times. He was a published bestseller as a teenager, and can speak Portuguese, which comes in handy because his husband, Bruno, is Brazilian. In his professional work, however, one of the things that I was very struck by was he was actually one of the first people publishing the first identification of the HIV-specific cytotoxic T cell, the CTL epitope. And he's also on the task force and the principal investigator at NIH's Martin Delaney collaboratory for the HIV Cure Grant, which is the Believe grant. So both of these gentlemen are working in their daily lives around HIV, AIDS, and supporting our community. And I'm really, really honored and thrilled that they're joining us here this morning. So thank you very much both for being here.
It's a pleasure.
So what I thought I'd start with, and I'll ask both of you to comment, let's just give us the update of what you both know, and maybe take 90 seconds to 1.5 minutes to 2 minutes each on what we know about the virus right now. Because I think every one of us that reads the paper or reads the internet on an hourly basis, although hopefully you're not reading it on an hourly basis because you go nuts, but finds different information every day, right? It lives on metal for 12 days, it lives on metal for 2 days. We're having more success with the social distancing, we're not. So maybe let's start with Doug. If you could give us your thoughts on sort of where you see the virus and what we need to know now, and then David, the same.
Sure. So thank you for the invitation. Good news in China, Hubei province probably is going to relax some of the social distancing measures so that there are definitely thoughts that this pandemic can be beaten. That's the good news. The bad news in New York City, we are the current epicenter in the United States. The hospital at Queens is full. We are running out of ventilators. And one thing that's just come up this morning that is causing a lot of interest is that it appears, although we don't know reasons why, that the Latino community is particularly getting hit. So there's a lot of intense interest into trying to understand whether that is related to the virus, to cultural factors, or to factors that we don't know. So that's my 1 minute update.
Thank you, Doug. And David?
Yes, well, thank you. I think that's exactly right. I think that we've had double-digit growth of new infections daily in the United States over the past week. I think the number yesterday was 25% increase in new infections, with over 500,000 new total infections in the country. We're at the beginning of this epidemic, not in the middle and not at the beginning and not at the end. We're at the beginning. I don't see us coming to an end in the near future. I think we're talking about months, not weeks. And the reason for that is that our testing is still way behind. So if people try to get tested and have mild symptoms but have no known contact, they're turned away. And so we need to increase testing, which we hope will happen over the very near future. But I don't think we have a handle yet on this epidemic. The good news out of China is balanced by the news out of Hong Kong, where they actually had started a return to work and then rescinded that yesterday because of increasing numbers of new cases. So it's important that people understand the epidemiology and work very carefully with public health officials in making decisions about what to do in terms of working from home or returning to more normal activities.
David, let me follow up on that. And then Doug, I want your thoughts on this as well. So you said 2 things that I'd like to follow up on. One, important that people understand the epidemiology. Can you give us a little more background on sort of what you understand the epidemiology to be that folks may or may not know? And then let's talk about how you see the curve and what your perspective is on that.
Well, I think it's really reflected by the governors across the country, where we're seeing more and more shelter at home edicts come out from various states. Certainly, the response has been slow. I think the populations who are hit are populations who are out and about, who are engaged with others, who are socializing. You know, I'm sheltered in Fort Lauderdale. I'm normally in San Francisco, but I did a 15-mile bike ride this morning, and the beaches are closed. There are police at each entrance to the beach in Fort Lauderdale, keeping people from going on the beach. It's the kind of social isolation that we need in order to keep this from really exploding. And I think for every person that we know who has this virus, there are probably 10 that we don't know.
Doug, your thoughts?
Yeah, no, completely agree with that. In terms of epidemiology, I think that, as David said, governors are incredibly important. There are sudden hotspots in the US. So New York City and New Orleans is having an explosion of cases, but really any place in the country can be affected, or and I think it is really, really important to emphasize minimal contact, social isolation, social distancing, because without that, we will never get a handle on this. And you may have heard Tony Fauci talk yesterday about the worry that this might become a cyclical infection. And so other viruses which we're more familiar with, like influenza, has a cycle. And the concern would be something more deadly like COVID-19 might come back. And it's sobering to hear David's comment about Hong Kong. I actually did not know that. That might be related to a number of factors, but we don't know enough about the virology to know how long people are infectious after a negative test.
And I've read several things about people being able to get it again, potentially, but we're unsure about that. Do you have a thought on that, either of you?
There are reports of about 100 patients out of, at that time, about 100,000 patients that have been reported as having had a reinfection. A very small rate of 0.1%, if you think of it in those terms. And it's hard to know how well documented those cases are. They didn't always check and make sure people had a negative test result before they called them cured. Most of these were in China, others in Japan and Korea, though. And so I think we just don't know at this point. Generally, from a virology perspective, we would expect people to not be reinfected, that their immune system would prevent that, but it's possible. And so at this point, we don't really know, is it the testing, is it the lack of clarity around that, or are people really being reinfected? If they are, it's at a very low rate.
Yes, we just don't know yet. I completely agree.
Well, I guess that's a small bit of comfort anyway. Before I go to the next question, I do want to pause. If folks on the line do have questions, on the right-hand side of your screen, there is the opportunity for you to post a question, and I can see them, and I will, as we go through, not just at the end, happy to ask our amazing guests here questions as we go through. So I like the not the myth busting, but the clarification on some of these things, which I think is very, very helpful. Let's talk about transmission and what we know about transmission, what we don't know. Could both of you give me your perspectives in terms of, we've seen everything from Amazon boxes being challenging through to living on metal for 12 days, through the plastics to, what is your perspective in terms of things people need to know in terms of protecting themselves?
Well, essentially, this is a virus that's spread by droplets. So it means that the most common spread is by people having droplets from sneezing, coughing, or even talking to a person who's within 6 feet of them. There's a confusion about a New England Journal of Medicine article that recently was published that was done by the National Institute of Allergies and Infectious Diseases and CDC, where they tested 5 different things. One was aerosol, one was cardboard, one was plastic, one was steel, and I've forgotten the last surface, but another surface that was common, copper. I wouldn't have chosen it, but copper. And what they found is they could still detect virus in cardboard up to 72 hours later. The same was true with steel. I think plastic was about 48 hours. Aerosol was 3 hours, although the testing wasn't done beyond that. But the problem with the way that people read that is this is an ability to detect any virus at all. And so the expectation is that a small amount of virus, which is what they were finding at that point in time, was actually probably not something that would cause infection. And so if you really look at it, we don't have good guidance for how do you know how long something can live on a surface. They also looked at the half-lives in each of those situations, and they ranged from about an hour to 2 hours to about 5 to 6 hours. So that means that half of it is gone in that time, and then half again after that for each time. So I think the main thing around that is to think very few people will be infected in this way. High-touch things like doorknobs and tables that many people come to in a cafe or something are things to avoid touching if you can, or if you have power over them in a workplace, to make sure that they're cleaned frequently. And it's killed with simple washing of your hands or with alcohol rub. And so making sure that you use that if you're touching those kinds of surfaces. But the main danger really is from other people, and most of the danger is from people who don't know they have the virus and could spread it in that way.
Can I just add that we're seeing quite a few cases of COVID-19 patients with diarrhea, and you can isolate the virus in the feces. So there may be the potential for fecal oral transmission. So that would just be the additional potential transmission route. It's a contagious virus.
That's really helpful. David, did you want to follow up on that?
Well, I was just going to say there are certain sexual practices that people are suggesting you shouldn't do. So rimming is probably something that's not a good idea right now based on that information. And social isolation makes it a little more difficult. So hopefully people can use video opportunities like in a more creative way.
Well, I was heartened to see that I think it was New York State did a guidebook on safe sex during the COVID virus, which I was really pleased to see. So we've gotten a lot of questions on the side, and I'm going to start to incorporate them. I do want to shift and let's talk. We are just broadly going to talk about HIV, LGBT treatments, etc. So for those on the line who are asking questions in that vein, those are on our docket to get to in the next little bit here. There was one question that was a follow-up question, though, that I wanted to pose to Doug before we moved on. You mentioned one of the colleagues on the line asked if you had any more information on the Latina or Latino or the Latinx community incidents that you mentioned. Was there any other additional information that you could provide on that?
No, I just heard about it this morning. So I will be following up and can certainly report back.
Okay.
But it's the highest prevalence in New York City is in the borough of Queens, followed by Brooklyn, followed by Manhattan and the Bronx, and there are not many cases still on Staten Island, although that will change. But Queens is the disaster zone in New York. Got it.
Okay. Well, and as I mentioned at the start, we will be following up with these gentlemen and others in our community, and ideally having a weekly, if not more frequent update as we can share information with our global audience. So let's talk about HIV, AIDS, and those living with either condition. And David, I'll start with you, and then move to Doug. Are people obviously with compromised immune systems are much more vulnerable. But those that are undetectable, I've understood, are at no greater risk, et cetera. But maybe you could kind of talk us through your perspective on what we need to know, both for those living with HIV or AIDS or friends and family.
Yeah, there is a recently published, I think 3 days ago, the Department of Health and Human Services issued a guidance on people with HIV and COVID-19. Which essentially says what you've just said, that obviously if your immune system is compromised with a low CD4 count, then you're at higher risk for any infection, or any infection actually not just occurring, but having a more dire consequence. And so people who have a low CD4 count are people who would want to make sure that they practice all of these things that we've been talking about to the extreme. I think for people who are HIV positive with a relatively normal CD4 count, well controlled, I think it's the same risk as anybody else. The virus doesn't know you have HIV. I don't think it's going to discriminate in that way. I've also been asked if gay and lesbian people are at a higher risk for COVID-19. Again, it's only based on activities and where you are. The virus itself wouldn't distinguish your sexual orientation. So I don't think that's an issue.
Sure. But I guess following on that, though, I guess as a community, we do have higher incidences of smoking, of alcohol abuse, drug abuse, higher incidences of HIV. So would you anticipate that as a community, we may be more hard hit?
I think it again relates to what kind of reaction we have in terms of protecting ourselves. This is a very hard ask for people who are generally very social. And people have said that Italy is one of the hardest hit countries, and it's people who are socially active, have big families, are engaged in large gatherings. There was a big party in Miami a couple of weeks ago, and we've heard of a number of people who actually became infected at that party in communities all over the country and really the globe. And so it's issues like that, really finding an ability to pause and to say over the next several weeks to several months, we need to really take a step back and protect ourselves in order to keep it from spreading further. It's not sexual activity that causes the spread, it's really close contact. And so that's really what we need to look at.
Doug, any thoughts on that?
I would totally agree with David. Social interaction is very normal for us all, and that's the way that the virus is spread. In relation to the question about people living with HIV, there were 140,000 people living with HIV in New York City, and I've been trying to keep a very close ear to understand whether the community is getting hit. And the good news so far is that it does not appear to be so. I'm on a daily basis trying to understand from the emergency room visits what is happening, and this morning was talking with some of the providers, and so far it's not been different. People living with HIV can be infected with COVID, but we have not seen our ventilator population disproportionately increased with people living with HIV. In New York City, we're also having this strange phenomenon where half of the people who are getting ventilated are in their 20s and 40s. And so I think another message would be, independent of HIV status, just in relation to age, we must make sure that our LGBTQ population realizes that it's not just people at the upper age, it's people at all ages. And I think that may be a very important message to try and bring through.
I would underscore that. Everything I read, from the beginnings, we were only focused on the elderly, and people felt like they were immune if they were in their 20s. And to your point, we've seen a number of really, really sad stories of those being affected or dying. So I want to get a couple questions from the audience that have come up while we've been chatting. One question actually was around face masks, and specifically asking around how effective they are. And I'll actually just read the question because I think it's quite well put. Not the N95, but simple surgical ones. I've seen the medical community divided on this, particularly in Europe. Here in Hong Kong, so this person is writing us from Hong Kong, wearing a mask in public has been part of the social pact and a sign of solidarity. What is the view in the US?
Well, generally, those types of masks are designed to keep in whatever is inside you already and keep you from spreading it to someone else. So if you have COVID-19 and you have to go out into public, it's the perfect thing to put on and to keep spreading it from someone else. These are designed as single-use masks. So if you think about it, either side of the barrier, if COVID-19 comes on the outside or comes from the inside, The concern is if you put it on the outside and you take the mask off and grab the front of it and put it down, you've just defeated the whole purpose of the mask. I saw somebody with gloves the other day touching his phone with the gloves, and I said, you know, if you're protecting yourself from something with the gloves, then putting your gloves on your phone is not protecting you from what's on the outside.
Right.
You know, there is a belief and certainly in Hong Kong and China and other Asian countries, it's much more common to wear masks as a regular basis for preventing of other common viruses. And so there may be some benefit for that, but really you'd have to pretty much be able to change it frequently, and people just don't have those sort of supplies. So I think you probably are actually even perhaps increasing your risk if you're in public and something gets on the mask and you keep reusing that same mask over the course of the day. There is a division on this, and I do think some people believe it, and certainly if everybody's wearing a mask, then you may be covering people who are asymptomatic, who actually have the disease, and so they may be containing it, and so in that sense it might be helpful.
I would just add to that that for healthcare professionals, we are running out of N95 masks, right. And there's been some very creative, urgent experimentation between Cornell Medicine and Cornell Ithaca to try and work out alternative ways of reusing masks through irradiation and other strategies, and that's showing some promise, but there is a shortage for healthcare professionals of N95 masks.
So in some ways, a social contract would be don't order the masks, let the medical professionals have access to them because they're the ones that need them on a much more daily basis, maybe?
Certainly with the N95 mask, that's very true.
I would agree. I mean, we just don't have enough masks, and we've seen situations in other countries. I was watching the BBC News about Iran, and they don't have enough masks, for example.
Right. Well, speaking of other countries, we've had a question from Italy and a question around South Korea. So I'll start with South Korea, and I'll just read the question as it was submitted. When comparing the evolution in cases, South Korea's curve is noticeably different. Is the data sufficient in concluding that South Korea is doing something different than other countries affected by COVID-19? And is there anything the rest of the world can learn about this? So I'd open that to either of you.
Yes, the answer is yes. The first thing they did is lots of testing. And so they were testing everybody, not turning people away. They were using a test that was developed in conjunction with the World Health Organization, which was a test that we rejected here at FDA. It's probably not as sensitive as the test that we're using in the US, meaning that you may get false positives, but I'd rather have a test that has false positive than false negatives, so that you actually may call something positive when it may not be. But I think that's been instrumental. I've also done really amazing screening approaches. You know, there's this controversy about temperature screening. Many buildings now are requiring that you go through an infrared gun and have your temperature checked going through.
Yeah, airports as well, right? Yeah.
Airports as well. There are very few. I mean, the South Korea did a study about 6 years ago with the SARS virus being prominent at that time. And they screened over 300,000 people during this time period with both a questionnaire asking them, do you have any symptoms, and listing those, and a temperature gun coming through. And what they found is that there were about 600 people out of that 300,000 who actually had a symptom that they reported on this form. And only 6 people among those 600 had a fever. And they detected 0 people who had a fever outside of those who filled out the form. So I think the idea behind it is really interesting, because what it does is it makes people aware that if they have a fever, they shouldn't be traveling, they shouldn't be entering buildings. So hopefully people are checking beforehand. But if I had a fever and wanted to travel to South Korea, Tylenol is readily available to take care of my fever. And so I think it's, in my opinion, not a great way to do it, unless what you're really trying to do is raise awareness that people who are sick should stay home and not be out in public. And I think that's an important part of it. But to me, the main thing that they've done is really a lot of testing of people with any symptoms at all.
And I want to key on one thing you said. They used the WHO test that we rejected. as you know, I think there are a litany of things that our country has done wrong, obviously starting from the leadership of the president and the misinformation he spouts daily. I saw NPR in Washington actually won't cover his press conferences any longer because of the misinformation, which is fascinating.
Well, I think he's right that this should be done by Easter. He just didn't tell us which year.
Fair. Well, there was also another question from Italy, and the person said, we're in the high peak of the virus crisis. I know social isolation is crucial to reduce the hotspots and spreading the virus. This, however, has a huge psychological impact, and especially on those who are alone, which this is my own commentary, LGBT people tend to be alone more than a lot of other groups. And so I guess a question for either of you is, how as a community can we try to combat that? I mean, as you said earlier, we are a social community by nature. Any thoughts on that?
So we have happy hour over Zoom for people at Cornell and for my lab, and I check in with every member of my staff on a daily basis on Zoom, so FaceTime, and I think that's helpful. We should also really pay attention to people that we know are living alone and put more effort into contacting and talking to them and putting them in contact with other people. So at the moment, I think that social isolation is the way that we will beat this infection, and it is causing enormous problems, of course, but at least being able to see someone and talk with someone is extremely helpful. At Cornell, they've also set up a FaceTime line for people with anxiety and questions, and that's really reassured a lot of people because they have a pretty robust answering system there, and people will just talk through everything. And part of the social isolation, if you turned on news and listened to news all day, it's quite depressing, right? So, for example, I also make an effort to spend at least a certain proportion of the day talking to someone. I mean, I love talking to Bruno, but there's a limit to what you can do at home. But to make sure that you talk with other people, and also to limit my time reading news.
Yep.
I think that's all good advice. My husband plays tennis in the Gay Lesbian Tennis Association, and last year played 27 tournaments all over the world.
Wow.
He's a very good tennis player, but also very social. And so what they've done is a similar kind of thing, not a cocktail hour, but they do a chat. So they do FaceTime or Zoom and meet with each other live. And it really is great, even if you just schedule 15 minutes or half an hour, just to have that social contact. So certainly would advise that as something for people to do, and to find a way to reach out and be with other people virtually if you can't be with them live.
Well, I want to highlight one resource that our leadership has actually just launched officially this morning. We sent a press release out just prior to this webinar. Last year, we partnered with an organization called 10,000 Coffees, which is a global mentoring platform online. And we piloted it for our Out Next emerging talent program. And if you're not familiar with Out Next, we launched it 7 years ago to convene and develop the next generation of LGBT leaders in our community all around the world. It's the first and only global program of its kind. As part of that platform, we instituted a partnership with 10,000 Coffees so that our young Out Next leaders could find mentors and sponsors through this global platform. And we've had almost 800 of those young leaders in the last year use the platform. So in the last week and a half, we've worked with 10,000 Coffees and have come up with a way to expand the access to that platform to every single member company of Out Leadership, all 81 companies, and every single one of their employees globally. That access is live as of this morning. So any member firm leader anywhere around the world can log in and connect to another Out Leadership member firm, senior leader, junior leader, or just a colleague to create those connections, not just for mentoring, obviously, but to try to create the social connections that we're talking about as well. We'll be sending out another link to that after this with some of the resources that have been mentioned here. And Doug, maybe if you can send me the information on the Cornell FaceTime chat, I think we could include that as well. So I want to go to a couple questions that are on the line here as well, and also start talking about treatments, potential cures, vaccines, et cetera. There was a question just prior to diving into that around why are we learning, or how are we learning about new symptoms only now? Is the virus potentially mutating? Is it possible there are different strains in circulation? And is that impacting different fatality rates?
Maybe I can start on that one. So there are different strains, if you like. There are variations in the virus. There's a lot of activities in sequencing. However, it probably is not as changeable as other RNA viruses. So I think that as far as I know, there haven't been any major mutations, but there are strain differences, and we don't yet know enough about those strain differences to understand if they are really causing different symptoms. I think it's an interesting question about, are we identifying newer symptoms? One of the things, as I mentioned earlier, that we're seeing here in New York is more gut related problems. So we're seeing gut issues, we're seeing stomach pain, we're seeing diarrhea as some of the initial symptoms. So I think that may just be a reflection of additional information coming in. And I've been looking at some of the many preprints, which are before peer-reviewed publication online from different places. And I think that if you look at those, gut symptoms were recognized in China, but people have focused on the major ones, which are fever and a cough and myalgia. I mean, I think there's a video online posted by the professor of medicine in Birmingham, Alabama, a wonderful colleague called Mike Sag, who's a leader in HIV research. Right. And he got COVID-19 quite early, and he talks about a period of intense pain. And that was a surprise to me. And so I think as more people become infected and talk about their symptoms, and symptoms are recorded, we'll get additional things coming up. But I don't, as far as I know, we haven't seen a major shift in the virus.
Mm-hmm.
Yeah, I agree. I think what we're hearing is still fever, cough, and shortness of breath are the three most common indications of the virus infection. But fatigue is very common, and GI effects are reported from the beginning, cases in China as well. So I don't think it's a shift. I think we're perhaps hearing more about those that happen in 20-30% of people, as opposed to 60 to 80% of people with the more common ones.
So in terms of treatment then, I know Gilead has been working on a lot of different drugs, and there have been, again, as we said earlier, all kinds of information, misinformation. HIV drugs could be the cure, then they were not, then malaria drugs, then the phosphates or the things that were in fish food that some couple in Arizona ate because they thought that was going to cure them because Donald Trump told them so. I mean, let's start with that in terms of, and maybe David, let's start with you from a Gilead perspective, because I know you guys are in trials with a lot of different pieces, and even in Congress yesterday. What's your perspective on how this plays out?
Well, a couple of things. I mean, because it's a new virus and we have viral drugs out there, people have said, let's try these viral drugs and see if they work, without really a good scientific basis. And probably the most strongly reported one is using Kaletra, an HIV drug that many people use. It's a combination of two drugs with a booster in it. But it was shown in a clinical trial to have no effect, and so not something that would be going forward. The drug that Gilead is in trials on is called remdesivir. It was a drug that was developed for Ebola, and in the Ebola tests, there were other medications that did better than remdesivir, and so we stopped developing it for that purpose. But it's been shown to have activity against other coronaviruses, including the SARS virus and the MERS virus. And so, and in the test tube looks very good. There are now 6 trials. The first 2 are being done by the Chinese government. Those, I believe, are complete. The one in severe patients, I believe, is either completely enrolled or almost completely enrolled. There's also one in mild to moderate patients they're doing. The other 4 trials, 2 of them are Gilead trials, which are now up and running. There are 2 trials, one from the National Institutes of Allergies and Infectious Diseases, and one from the World Health Organization. So all of those are looking at. Remdesivir is not an easy solution. It's an IV infusion and given over 5 to 10 days. So it takes about 30 minutes to do the infusion, so it's not just popping a pill. So we'll see if it works. We're hopeful, but at this point in time, we don't have any data. There's also been a compassionate use program, which required each doctor to call in each individual patient and get approval for them. They had to be on a ventilator and have a confirmed COVID-19 diagnosis. That program has now been changed from an individual basis to what's called a more broadly a compassionate use program that allows an institution to once, and then any patient can be qualified without further registration. That changeover is happening right now, and so that should be something that we'll be able to see a easier ability to get drug. Again, we don't know if this drug works. The nice thing is we have a lot of safety data from the original trials in the Ebola trial, and it looks like it's a fairly safe drug. And so that's helpful for a drug at this stage in development to be able to move it this rapidly into human trials. And the disease course is so short, it's not like testing an HIV drug where it takes us 3 years to get results. This is a matter of months. So.
Well, that's positive. And Doug, and thoughts on not just the Gilead pieces, but some of the other things that we're seeing recommended even by our president?
Sure. So before I jump into that quagmire, there are other antiviral agents that are being tried. Obviously, we think that the Gilead remdesivir drug is the most potentially promising, but there are others in the pipeline, the names of which I normally get wrong because I'm not so familiar as David is with the names, but my colleague Esper Calas in Sao Paulo, Brazil, is doing a trial sponsored by NIAID, the National Institutes of Allergy and Infectious Diseases, on galidesivir. And galidesivir is a drug that had been specifically designed for yellow fever virus, and had gone through a phase 1 trial, and Esper Calas, who's the professor of infectious diseases at the University of Sao Paulo, had for the last year gone through the paperwork to use that drug in the yellow fever outbreak in Brazil. Fortunately, that yellow fever outbreak dissipated, and he had the vials in his fridge. And the sponsoring company has some data suggesting that this may have efficacy against coronaviruses. And so he has got permission from the company and sponsorship from the NIAID to run a trial. It's a small trial. And then there are other antivirals that are being tested, and there's an intensive effort to look for drug repurposing, which basically means to take a drug that's already been licensed and used in other circumstances and see if it works. So that's one of the greatest things I've seen, that everyone is coming together to try and see what agents actually do work. But as David well knows, and that in order to show that something works, you have to have a properly conducted study. And anecdotes are helpful in the sense of allowing us to focus in on designing proper studies to understand if something works. And the good thing, as David said, is, well, good and bad, is that this virus is quick, so that we're going to get rapid answers. But I think seeing the dance between Fauci and Trump on stage is, I'm not sure how I would describe that courtship, but Fauci is correct. We can't make pronouncements about whether something works until a proper study has been done.
Right. You also ask about vaccines, and there are a number of vaccine candidates that are being reviewed as well. But again, if you think about what Tony Fauci said, it really is a year at the very earliest, probably more like 18 months to 2 years, if you're lucky and have a good candidate. So that's not. And again, vaccine is to prevent it for somebody who doesn't have it, not to cure somebody who does have it.
Right. Well, and I think that's something that, from a social distancing perspective as well, 3 weeks, 6 weeks, 9 weeks, 5 months, whenever it is that we sort of start reintegrating in society, those who have not had it will still have to be on hyper-vigilant alert, right? Because it won't have just disappeared. It will just have dispersed. I want to get through a couple quick questions that hopefully maybe I'll just give to one of you so that we can get through. And we may go a couple minutes past 11 since we started a couple minutes late, if that's okay with both of you guys. Do you guys need to, like, 5 after maybe? Is that okay?
That's fine.
Excellent. So at the very end, we're going to talk about what people can do to support first responders and what companies and leaders in companies can do. So we'll kind of end with that. But there were a couple questions that were more tactical. One person said, do we have any information on the expected peak for New York City and for New York? And I don't know which of you would want to take that.
So maybe we have daily conversations on this, and the predicted peak in New York City is 3 weeks from now. 3
weeks. Okay. Wow. Interesting. And so if it's 3 weeks, yeah, go ahead, Dave.
Yeah, it's a guess. It's an educated guess. Hopefully that's true, but it depends on a lot of things. So that would be great if it is 3 weeks.
That's why I said predicted. Yeah. Things can change.
Yeah.
We won't hold you to it, but that's
typically predicted.
And then I know there's been a lot of information about what you should do if you feel like you've got it or you're sick, but just, in the interest of educating those on the phone, if they do feel that they have COVID-19, fatigue, fever, aches, the cough, etc., advice, what should they do?
Socially isolate, check with your healthcare provider, see if you can get tested. And I think testing within the next 2 weeks will be much easier to obtain than it is today, but still push for it and don't go to the emergency room. Call your provider if you can and check with them first. Rooms don't want to deal with everybody who might have mild symptoms. Obviously, if you have serious symptoms, that's the time to call first and then go to an emergency room.
And I would just go ahead, Doug.
Yeah, and I would just add that I think this is a time if you do have symptoms to self-quarantine, not just self-isolate, and to alert people around you that may be able to help you, because one of the clinical paths can be rapid, and so particularly if you are living alone, you need to be able to call several people and say, I've got shortness of breath, I need to get to the hospital, can you make sure I'm in an ambulance? So you've got to set up that network. And then people's symptoms are quite variable. But in New York, it is not possible. You will not get a test. There's no testing. You won't get a test in 2 weeks' time. And so the advice is that stay at home. It's likely you do have COVID-19 if you have these symptoms. There's not much flu around at the moment, and it's likely you have it. But just keep in regular contact with your doctor, monitor your temperature, monitor your symptoms, but above all, set up that network so that you can rapidly get help if you need it. And then the other thing is that if you go to the emergency room, you will get COVID-19, even if you haven't had it, because the emergency rooms are completely full everywhere, at least in New York, of people with COVID-19.
Yep. There was a follow-up question on HIV. Any additional risk for individuals that are HIV positive, undetectable beyond those that are not positive? So
No, I think there's no additional risk. Again, assuming you have a CD4 count that's in the relative normal range, and I would say probably anybody above a 350 CD4 count probably has a fine immune system for responding at this point. Certainly higher than that is what we all want, but that is below which I would have perhaps slightly more concern.
I would agree.
Last thing I want us to talk through, just for a couple of minutes, and I'd like both of your perspectives on this. From a corporate perspective, what could companies be doing now for their employees? What could employees be doing for each other? What could we as a community be doing for each other? What sort of advice would either of you give? And David, let's start with you, and then I'll go to Doug.
Well, I think corporate responsibility is key here to make sure that people really are taken care of, both from an employee perspective, but also for those of us in the industry that work in healthcare, to make sure that we're doing all that we can. I can tell you that my day lately starts at about 5 a.m. and ends at about midnight, so it's very involved. And I think that's true for many people working on this disease in different areas. But you know, we have to think about the people in small businesses, the people who, you know, serve us food, the people who are out there who don't have a regular income source, and to try to find ways to make sure that those people really get through this crisis, not just healthy, but also to not be financially ruined by this crisis. So really thinking about ways to do that. Let's be charitable in whatever way we can in helping people out in those situations. And I think really corporations doing that, to have extended leave policies, to make sure that people have healthcare coverage and work with people on those lines, to think about issues like childcare and elder care. Can companies help as providing those services if already? So I think there are a number of things, but really putting the people first and finding a way to do that. Healthcare providers, I think, will be asked to step up to the plate, and that's already happened in New York, where every licensed physician has gotten a letter from the governor asking them if they would be available for helping out if needed, specialties and other issues. And so really looking at that, and corporations like mine are looking at policies for giving people leave to go and help out and to do that. So we'll see more of that, and it may be that we'll need that in places where that are the epicenters.
Yes, I won't address the corporate angle. That's obviously super important, but I think that helping remind politicians of the LGBTQ community and what's going to happen when COVID-19 spreads in the population, and also to lobby for more research dollars for COVID-19 and HIV co-infection. I think that's not been on anyone's radar. So, you know, anything that can be done in that angle. And then the last thing would be to just encourage your Out Next group to remind young people that they too can become infected, and they also have a social responsibility to stop the infection, and they themselves can get sick.
Well, I think those are all incredibly important things for us to remember, and we'll share those in a follow-up. And obviously, as a community, we've already lost a number of leaders and luminaries. Just 2 days ago, we lost Terrence McNally, who for many of us was an idol and an icon, and luckily a friend of many of us. And his husband Tom is carrying on his legacy. I actually wanted to just close today's webinar with a quote from one of Terrence's plays that I thought was actually quite fitting. His play Masterclass. So those who've seen Masterclass, it sounds like you both have, won 4 Tonys, 2 when it came out and 2 in revival. And it was a fictional masterclass by the singer Maria Callas. And if you've not seen it, it's absolutely worth it. Patti LuPone and Audra McDonald were stars at different points in the show. But the closing monologue I thought was a perfect way for us to end the day. And she says, "If I have seemed harsh, it is because I've been harsh with myself. I'm not good with words, but I have tried to reach you, to communicate something about what I feel, what we do as artists, as musicians, and as human beings. The sun will not fall down from the sky. There are no more Traviatas. The world can and will go on without us. But I have to think we have made this world a better place, that we have left it richer, wiser, had we not chosen the way of art. The older I get, the less I know, but I'm certain what we do matters. If I didn't believe that, you must know that what you want to do in life, you must decide, for we cannot do everything. Do not think that singing is an easy career. It's a lifetime's work. It does not stop here. Whether I can continue singing or not, it doesn't matter, because it's all there in the recordings. What matters is that you use whatever you have been given wisely. Think of the expression of the words, of good diction, and of your own deep feelings. The only thing I ask is that you sing properly and honestly. If you do this, then I will be repaid." Well, that's that. Blackout, curtain. So I want to thank you for doing what you can with what you have. And I want to thank you for all the great work that both of you are doing. I really do hope that we will continue to see progress. And I want to thank all of those who joined us today for this webinar. I hope it's been useful and resourceful, and we will continue to take comments and questions from you and ideas for future webinars. We'll be doing at least one a week, and we hope that you'll find it useful. So Doug, David, thank you for joining us. Thank you for all your important work. And to those on the webinar, thank you for joining us, and we hope you stay safe. Take care.
Thank you.
Thank you.